Yeah. We will get a prompt here.
Yes. Okay. All the best, Dipanshu and Dr. Kaushik.
Is my screen sharing seen?
It's and Dipanshu Agarwal has started sharing the screen. The slides are not.
I don't think it is seen. It is not seen.
It is just, it has started sharing the screen. It's not visible yet. Dipanshu, quickly email me your presentation.
No, I have this. Dipanshu, let me share. Just unshare this. I'll share from my mobile.
Nilesh, you can put in YOSI groups that we are live now.
Yes, ma'am. I'm doing that.
Thank you so much.
Ma'am, I have mailed you a PPT. Please download it. Kaushik sir, are you sharing?
Yes. Down. Is it visible?
Yeah.
Yes,
It is visible now.
Dipanshu, please start.
yeah. Very good evening, one and all. So we have gathered here for another exciting session in the series of medical legal aspects, which is conducted by YOSI. So can you move? This is our core legal team. We have been organizing these sessions on a monthly basis. We have had 8 sessions so far. It has been based on consent, documentation, medical records. Then a few of the topics like cataract surgery and medical legal aspects, telemedicine, endophthalmitis, TARS. All these topics have been covered so far. Now, today we have gathered for our 9th session, that is retinopathy of prematurity and related medical legal aspects. And it is a very important topic in the today's era, since retina and ROP related litigations have seen steep rise in the past few years. For today's session, we have eminent panelists. First of all, we have Dr. Anil Deshpande, sir, who is the director and eye surgeon at Guru Prasad Netra Rangnala, Aurangabad. He is also the director at Indian Medical Legal Consulting Services Private Limited. Sir has served as the chairman of various legal committees like AIOS, MOS, and KOS, and he is also the faculty of law and visiting professor of Symbiosis Law College in Pune. Sir has written various books like Legal Aspects in Ophthalmology, and this is to name a few. Next upon, we have renowned Dr. Prakash Marathe, sir. He is consultant ophthalmologist at Netra Yogi Eye Clinic, Pune. Sir has also served as a senior vice president, IMA Maharashtra State. He is also the managing committee member of AIOS. Also, sir has served as trustee and past president of Pune Ophthalmological Society and as well as IMA Pune. Sir has also served as past president, Maharashtra Ophthalmic Society. Sir has special interest in medical legal cases. We welcome you both, sir. Next, I would like to introduce speakers for today. First, we have Dr. Anil Gangwe, sir. Sir is a consultant veteran and ROP services at MGMI Institute, Raipur. Sir is a alumni of St. GS Medical College and RP Center, AIMS, New Delhi. Sir has special areas of his interest lies in anti-VEGF in ROP and medical legal implications, neonatal care and progression of ROP. Sir has various publications and to his credit, and he has also introduced tele-ROP screening in Chhattisgarh along with less sparing vitrectomy for stage 4 ROP and further in Chhattisgarh. And sir has trained various ophthalmologists and fellows in ROP screening and treatment. And he has various publications to his credit. It is an honor for me to introduce my mentor from VR Fellowship, Dr. Anil Gangwe, sir. Welcome you, sir. Next up, we have Dr. Akash Patel, sir. Sir is consultant retina specialist and eye surgeon at Akash Deep Eye Care, Rajkot. Sir has area of his special interest lies in vascular diseases, retinopathy of prematurity, and venous occlusions, and he also runs one of the largest retinopathy prematurity program in private hospital basis in country. He has screened more than 10,000 neonates in the last 10 years, and he is one of the pioneers of usage of eccentrics in ROP. He is, apart from medical, he is also a financial advisor. He runs an online academy by name of Investing Coach and free group of by investment name of investment and wealth creation group on Telegram. Sir also has special interest in VR surgeries, phaco-refractive surgeries, and he deals with all the specialties of the ophthalmology, allied specialties like cardiology, anesthesiology, and gynecology, and they are the beneficiaries of this program. Sir also offers free membership and training in financial management training program to young widows of doctors who concentrated their life to battling COVID. We welcome you, sir. First, I would request Dr. Anil Gangwe, sir, to deliver his talk. Over to you, sir.
Okay.
Can you, Kaushik sir, can you?
Yeah, Dipanshu, I think you need to share my presentation.
Yeah, sir.
Yeah.
Aarti ma'am, can you share?
So I think good evening everyone, and thank you Dipanshu, Kaushik, Dr. Aarti, and the YOSI group for allowing us and inviting us for this interesting session on medical legal implications in ROP practices. So I think by the time we start, so I'll just
Can you share the screen.
Dipanshu.
Dipanshu, you said something. Yeah.
I sent the PPT to you. Actually, my screen sharing is not working. Sorry for
Yes,
that.
I'll download it. Just give me a second.
Okay.
Maybe till that time, our panelists for today, Dr. Anand sir and Dr. Marathe sir, can talk few words.
I think YOSI has taken great initiative in starting these medical legal topics, and under the series what they have started, and it's really beneficial for young ophthalmologists, and not only young ophthalmologists but all ophthalmologists across the country, because these medical legal topics are really very important, not taught in our medical practice, in our medical syllabus. Maybe we know about theory and practicals and surgeries and procedures, but medical legal aspects are really very important. And today's topic, that is about retinopathy of prematurity, was literally not known to many more neonatologists and pediatricians. They were not that careful about it. But once few court verdicts came and they were penalized because of that negligence, and crores of rupees were awarded, people are aware. And I think the retinopathy of prematurity is the thing which is correlated with 2 to 3 specialties, that is ophthalmologist, gynecologist, neonatologist, pediatrician. And it is the union of all these specialties so that they should work together and keep that particular child under observation so that to avoid retinopathy of prematurity and avoid further litigations. Thank you. I think the screen has been shared. Let's go ahead.
Yeah, thank you, Dr. Aarti, and thank you, sir. So I think I will start my presentation, and my main core area where I will be talking with how we should avoid or how we should be thorough in your documentation, and our documentation can help us to get rid of such litigation, or a poor documentation can actually put us into a medical legal litigation equally. So documenting ROP and its findings is equally important. So I don't have any financial disclosures, and there are many of the slides where I will be sharing some of the photographs or snaps. So I don't have, these are just for representation. Okay. So again, what I would like to say is previously we had publication on the same topic, how to avoid this medical legal implication. And Dr. Anand and Dr. Samarth, we have nicely summarized the entire thing. And basically, Dr. Samarth has very nicely summarized the previous medical legal implications or medical legal cases that were filed against Dr. Aarti. So I think on the next slide, we had that table. Dr. Samarth has very nicely summarized what were the pitfalls, what were the actually lacunae that were in their documentation, and what were the lessons that we learned. So in the last 1 decade, there has been a rising in the number of medical legal implications. And if you see in the United States, ROP remains the highest litigation kind of a thing in their medical legal practice. Next. So again, as a pediatrician, if you see, as sir was saying, if you look at the ROP and medical legal implication, it will start from the gynecologist, then to the neonatologist, and ophthalmologist comes to the last. So it's pediatrician's role that they are priming their parents about that the baby are preterm, they are going to require screening for ROP, and ROP is briefly a kind of disease of retina. So that once, suppose many of the times we just examine the baby for the first time and we just encounter that, okay, the baby has a severe form of disease and needs treatment. So the parent should not be taken by the surprise that the baby has a disease and needs treatment, and that too in an early stage. So it's our pediatrician colleagues' responsibility or job that they are priming the parents, so they are not taken by a shock when we describe the disease to them. So next. So actually, if you are talking about ROP and India, so we are supposed to follow the Indian screening guidelines, because if you look at the Western data and the Indian literature or any middle income countries ROP data, we tend to see babies which are quite larger and they tend to have a severe form of disease. So in India, to avoid such kind of litigation, we must follow the Indian screening guidelines, which are actually to screen any baby which is less than 34 weeks of gestation or has a birth weight less than 2000 grams. Dr. Aarti, yeah. So again, the same thing, ROP in the larger babies, and we must not follow some Western guidelines for screening ROP. Next. So again, many of us, or at least pediatrician, they are under the impression that irrespective of the prematurity or birth rate, if the baby has not received oxygen, the baby is not at a risk of developing ROP. So these are actually the quotes from the judgment of Supreme Court, where the AIMS directors or the group of people from AIMS NICU, and they have mentioned that ROP can develop even in absence of oxygen. So whether the baby received oxygen or not is not mandatory for taking a baby for ROP or not, because even presence of a room air oxygen is sufficient enough for the premature baby to get ROP. So oxygen should not be the factor to decide for or not against the ROP screening. Next. Again, very important thing, screening is very safe procedure and it would not put undue pressure on the child. And on the second side, ROP is a disease, or severe ROP per se is a disease of very sick and smallest kind of a baby. So as an ophthalmologist, we should not be denying ROP screening for any babies which is on either ventilator or CPAP, or so-called baby is not very stable. So you should not be denying from your perspective that I cannot do ROP screening, because you will get usually ROP in such kind of babies only. And even if explaining the need, if your pediatrician is not allowing you to screen for ROP, then it's a different perspective. And then you must ask your pediatrician, you must have a good communication that these babies would need ROP screening. Next. Yeah. So I think one of our participants, they have put up a question on whether we should have a consent for ROP examination. So here at MGM Institute, we are usually taking ROP screening consent, and we try to mention the method of examination. The leads will be swollen after examination. So we are following it, and I think sir will be better person to answer that question. But whenever you have an option, never hesitate to take a consent, and it should be, for example, in our this format, it is in English. So we should have a bilingual kind of a consent. It must be there in Hindi as well, so that the parents can read it and then they can sign it. So it is always preferable to have a general consent for ROP examination as well. Okay. Next. Then what is the ideal place? So NICU would be the ideal place for screening ROP babies. First, most of them are admitted to NICUs whenever we are screening them for the first time. And for any unforeseen event, we must have a pediatrician around in an NICU, and it is a warm kind of a place. We have all safety precautions. So it is a preferable, or nursery is the ideal kind of place to have ROP screening. Next. But I think still Dr. Kaushik had also put up a similar kind of question, that it doesn't mean that if babies are discharged from ROP their NICU, they can be very well examined in your ophthalmic OPD or even in NICUs. But we tend to call them even in NICUs. And if they are being examined in our general or ophthalmic OPD, we must tend to prioritize them. So we should see them before the adults. We try to mention their priorities. So next, these are the same things where we would prioritize. And if they are being examined in our ophthalmic or general OPD, we should designate a special kind of a room which is warm enough, something like NICUs, and the drops and everything is being explained to our staff so that they are also well aware how to go about the ROP screening. We must have a trained or designated kind of a staff who can look after the ROP screening preparation in NICU and who can look after the preparation in your routine OPD. Next. So again, follow all forms of aseptic precaution. Try to take different instruments for each baby. Wash your hands between the babies so that there is no cross contamination. There is no risk of nosocomial infections to the baby. Next. And before actually we are taking up these babies for examination, at least in our scenario, we have trained the ROP screening nurses in the NICUs wherever we are visiting. The nurses tend to counsel the parents that what is actually ROP screening, why it is being done, what is usual method of examination, and the baby will be having some pain, the baby is going to cry, and the lids will be swollen after examination for 2 or 3 hours. However, it will be fine, and everything is being done for preventing the child from getting blind. Okay. So this is, I think, the pediatrician or the nurse domain. She will help us in explaining the patient. And whenever we are doing screening for ROP babies, and if you come across multiple babies or babies with multiple gestation, then after examining a baby, we must actually inquire the parents about what happened to the second babies, what are the other babies, because sometimes the pediatrician, they may not advise ROP screening for the siblings just because the weight was fine, the weight was more than 2 grams. So it's our duty to also inquire about the siblings in multiple gestations. Next. So coming to the core point, actually, good documentation. A good documentation is the only thing which will help us to avoid such medical legal documentation. And sometimes whatever we are talking, whatever we are trying to explain to the parents, however, if we have not written it, we have not documented it, for all medical legal cases, it will be implicated that you have not done it, you have not performed the procedure. Next. So I think after those medical legal cases where the court of law specifically pointed out that the method by which the baby was dilated, who dilated the baby, how many times the eye drops were put, there were no records in the NICU or the baby's file. So after that, we have tried to incorporate a prefixed kind of information where we tend to describe the method of dilatation, how it was examined. So it is preferable to write it or have something like a pre-filled format, the method of examination. And if you are using tele-screening or RedCam for ROP screening, you must describe that the examination was done by a paramedical or the trained staff by using RedCam or something like NEO. So that will help you to safeguard against, again, future implications. Next.
Okay.
Yeah. So again, while we are documenting, it is very important that we describe or we try to document the demographic details of the baby, any risk factor, which are the hospital who is the treating, and there are significant anterior segment findings. At least in cases of ROP, we must write about whether there was good pupillary dilatation, NVI. So these are all points which will be either in favor of severe ROP or less severe form of ROP. So we must try to document this in a legible kind of a writing. Next. And while we are documenting ROP, as per the current standard, it is internationally accepted that ICROP3 or International Classification for ROP3, which is a relatively updated version. We should try and follow the updated version of the classification. Next. Yeah, the ICROP3 now divides the zone 2 into anterior, posterior. All those stuff we need to incorporate into our documentation. Now, if there is no ROP per se, then we are supposed to mention even in the slide that I am providing, the retinal vascularization is written as immature zone 3. However, the ICROP 3 doesn't support the terminology something like immature retina or immature zone 3. So what we are supposed to write is, it is like incompletely vascularized zone 3, or for something like mature retina or completely vascularized retina. So we should try and use the terminologies which are acceptable worldwide. Okay, so in absence of ROP, we must explain or we must write what is the extent of retinal vascularization in that particular infant. Next, if you are coming across something like AROP or APROP, in such cases, do describe what is the zone of APROP, because zone 1 APROP, zone 1 posterior APROP, they would have a different treatment implication. People may have different opinion about their management. So describing it right at the diagnosis will help you in the future. Next. And as I think Dr. Gaurav's question and further, if there are any additional findings which are directly or which may not be directly related to ROP, but we should start writing or make it a habit that we write these additional findings like hybrid disease, popcorn lesion, if there is any ridge hemorrhages, which are not usual or which you find they are not usual to this phase. Even for this particular case, there is a completely vascularized retina in the left eye, but for right eye, there is asymmetric kind of a disease which is in zone 2, and there is some serous retinal detachment. So even in this case, I have tried to document all those findings. And here importantly, I have written that I would like to take a second opinion from my colleague, Dr. Anil. So in this scenario, never hesitate to take a second opinion, and before taking a second opinion, best is to write that you would like to take a second opinion for these 1, 2, 3, 4 findings. So that's a good practice that will help you to be on the safer side, that you had some confusion or you were not clear about your findings and you asked for a second opinion. Next. And it's a good practice to write about the gestational age, the current weight, other additional findings which may be again indirectly related to the disease. Next, again, this is very important point, the mentioning the next date. So again, it's a good habit to write the exact date on which you would like to call the baby for follow-up. Something like writing 1 week, 10 days, 3 days is not good. And about, again, writing a date like in the format of date or day, month or year is rather avoiding any confusion. We tend to write like 9 February 2019. So there is no confusion between the month is earlier or day is earlier. Write it in a clear language, which is, there is no confusion even internationally. So if you have a legible handwriting, it's a good thing, and you must document everything in this format. If you are not having good handwriting, it is preferable to give a PDF version or a printed report, and you must sign it. Next. So again, ROP is all about documentation. You have to see so many babies and you are also overburdened. So to decrease your load and to have improved documentation, you can have your own diagrams, you can have your documentation sheet, and which you fill meticulously while you are doing the ROP screening at each visit. Next. So you can have your own pro formas actually. And again, something like Dr. Gaurav's question, whenever it is possible to have a photographic documentation, ROP will have very important implications with time. And as in his case, he had no fundus or neonatal fundus camera. So even nowadays, people are coming with low cost cameras. They are coming with handy mobile handheld cameras. So you should try and document whichever way it is possible, at least to get at least some view of the posterior pole, so that you are sure that you have treated it in the best possible way, and you try to document. Documentation will also imply that you had an intention to document your findings, so that will safeguard you. Whenever it is possible, you must do that. And again, while documentation, we must use the things which are universally accepted. something like using terms like grades of ROP, fundus appear normal, posterior pole normal. These are not the appropriate term that would be expected, and that will put you in trouble whenever things are not in right shape. Okay, next. And writing things, this is the same example. I have taken it from one of the notes. ROP normal. This is not a good thing to be documented from a pediatrician's perspective. Okay, and even from a ophthalmologist perspective. Next, again, same example for ROP. If we are trying to write that we are doing laser augmentation, PRP, barrage laser, so these will put you in trouble. So your documentation and using terminology will be very important. Next, and again, we must be very careful while we are discharging these babies from ROP screening. At that time, we must explain these parents that even if your child doesn't have any ROP, but there are chances that the baby may develop refractive error. The baby has higher chances of developing strabismus compared to a baby who is term. So even after follow-up, you should come for a regular visit to an pediatric ophthalmologist or a ophthalmologist at least for a cycloplegic refraction, or if there is any strabismus or squint in the eyes, you must come earlier. Otherwise, that can also become point. And always mention that these are the same things that I talked about. The babies may have a risk of squint, amblyopia, and refractive error, and it's a long-term kind of follow-up. Next, and again, at the end of your summary, you must write, sign, put your date and time whenever possible at the end of your summary. And this is all about documentation. Most of the medical legal liabilities and cases will arise whenever there is miscommunication, or the parents or either doctor failed to explain or the parents did not understand. Then only those conditions would arise. Most of our mentors, or Dr. Subhadra, she always tells that I think you should be spending more time talking to the parents, explaining the condition, and equally importance has to be given while discussing these findings with the parents. They are not from a medical background, and first they are suffering from the preterm baby being in the NICU for a longer time, and explaining them about ROP or severe ROP requiring treatment is going to take some load to the parents. So you must pay equal attention to their psychological status. You must spend sufficient time and answer their queries as far as possible. Okay. Next, please. So again, communication with the pediatrician and ophthalmologist is equally important, because there are some babies where actually things are not in right place. The baby is not getting in weight gain. There is oxygen waning. There is need for correction of anemia. All those things which you can actually see, there are things which can be corrected where you can be able to lower or decrease the risk of ROP or a severe ROP. You must discuss this with your pediatrician so that you can work as a team in preventing or lowering the risk of ROP. Next, and fixing the systemic issues is equally important. Treatment part is again, what is the standard of care for ROP? Again, this is not the right platform, but again, still today, laser should be considered as, or is regarded as, the gold standard for treating a severe form of ROP. Okay, and we must follow the guidelines which are led by ETROP. And again, it is very clear for even for a beginner, we would treat only in presence of plus or pre-plus disease. Okay, next. So again, if you are describing the findings of ROP, something like in this case, if there is zone 2 stage 3, we must write that there is plus disease. So again, treating in absence of plus disease is not a right thing, and at least in terms of documentation, it's not an appropriate thing. So must write it that there is a plus disease and that's why you are treating it. And when treatment is indicated, it has to be initiated preferably within 48 to 72 hours to have a good outcome. And it has to be mentioned. Again, always treat in presence of plus disease and mention that there is plus disease and that's why you are treating, and use appropriate terms. Again, NICU is the best place to treat. You must have all NICU backup emergency support from your neonatologist, and you should take all the proper precautions to prevent the complications like hypothermia, hypoglycemia, bradycardia, apnea. best thing would be to have a neonatologist around so that you are safe and you can focus on ROP laser. Next. So again, it is for our new beginners who are just picking up ROP, they are trying to do laser. It's not a good thing to do it inappropriately. Initially, everyone would find it very difficult to do ROP laser in a single sitting, and it's not expected also. You can do it in 1 or 2 settings. However, explaining it to the parents that, okay, you are going to do it in 2 or 3 settings is equally important. This type of incomplete kind of a treatment and then not documenting it will put you in trouble, because if such patient goes to someone, then you might have problem. Again, laser, if you have not done it appropriately, it is going to leave that scar, and as the baby is going to grow, you will be, and this will be evident in your fundus. So even at the age of 21, if you have done a laser which is very close to fovea, you have a chance of having problem, medical legal issues. Again, the same kind of thing. If you are having such a anteriorly unlasered kind of avascular retina, but you have tried to laser posterior to the ridge, not taking care of the anterior avascular retina, again, if the disease tend to progress in such kind of a scenario, and this patient goes to some of your colleagues and there is a need for retinal detachment surgery, then again, this type of evidence can actually prove against you. Okay. So follow-up, there is need for, again, refraction, amblyopia, everything needs to be explained to the parents. Anti-VEGF, I think this is entirely a different set of area, and we should be limiting ourselves that anti-VEGF has a specific role and its indiscriminate use has to be avoided, and a proper written informed consent which always explains that there is Avastin which is off-label use, then there are some approved drugs, and you may have some neurodevelopmental delay. Everything which is being published and reported in the literature, you must try to incorporate in your consent. Then only you go for anti-VEGF injection. And as of in India, this was a nice article written with Dipanshu and Dr. Anand Vinekar. At least what we have suggested that APROP in zone 1 is the appropriate indication. Drug, yes, you can decide for it, but everything that we have tried to written, must be explained to the patient. The parents should be given appropriate time to think over their options, whether they would like to go for anti-VEGF and which anti-VEGF they would like to go for. Next. And again, why I have put this question, again, looking at Dr. Gaurav's question, if you look at this photograph, these are the same, these are the 2 eyes of the same patient. Left eye appears to be doing good, even the right eye appears to be fine. However, if you look in the periphery, even after regression, next, you can see this, sorry. Yeah, you can see this, there is a peripheral laser retina plus disease is not there. There is no vascularization, tortuosity, but there is some peripheral traction which is developing into anterior part of zone 2, while the left eye is doing absolutely fine. So this, even in the best condition, the success rate of ROP treatment all over the world, including India, ranges from 90 to 95% of the cases. So even with the best kind of treatment, there are chances that the baby may still progress and may need additional treatment in the form of surgery. And this has to be explained to the parents and has to be mentioned in the consent also. So I think I will end up with the summary that what we need to prefer is you must follow the preferred practice pattern. If you are doing it in India, we must follow the Indian screening guidelines. Then we must counsel the parents appropriately. We must be informing the neonatologist, and a good documentation is must thing in your ROP practice. And we must keep ourselves updated. Particularly, more and more data is coming about use of anti-VEGF. So we must be updated. We must be explaining the same thing to the parents in the best possible language they can understand. And finally, is we all of us, of course, vitreoretina people or ophthalmologists, we must have a good professional indemnity cover, because with best kind of effort, things still can go out of your hand and you may land up in court. So financially, you should be supported. Thank you. Thank you.
Thank you very much, sir. That was
Yeah.
an extensive talk, and you have covered so elaborately all the specific key points for documentation. Thank you, Aarti ma'am, for sharing the screen. And now I would like to request Dr. Akash Patel, sir, to please share his screen and deliver this talk.
Yeah. Am I visible and audible?
Yes, sir.
So really beautiful talk by Dr. Anil Gangwe, sir. And he has really eased my job today because majority of the topics have been covered. I'll be discussing on the other half of the topics, which probably we need to tinker on as a ophthalmologist. And before we begin, I would like to thank YOSI for organizing such a wonderful event. It's a great evening, and with the blessings of Dr. Anand Deshpande, sir, and Dr. Prakash Marathe, sir. And wonderful organization by Dr. Dipanshu, Dr. Aarti, and Dr. Kaushik. We are here together. So to begin with, let us understand that ROP is really tricky disease, not only from the technical point of view, but it's also the diagnosis, the pathology, the socio-economic impacts that it comes with, the documentation, the legalities involved, and also the gray areas. So my focus would be chiefly on the gray areas which are involved in the treatment, but also in the documentation and the other parts of the ROP here. Please let me put a disclaimer as the first thing that I have no vested interest in any of the treatment modalities mentioned, and I'll be solely presenting the court cases on the merits of the citation interpretation of the same. And these are not any recommendations or guidelines from my end, and I don't hold any grudge against any of the doctors. Majority of the times we have not mentioned any names, but a couple of names might be mentioned. And I'm not a legal professional or do not wish to be quoted or cited when it comes to recommended practice, because it gets really tricky when it comes to formulating guidelines, and everyone should have their own guidelines. So members are encouraged to take a legal counsel as and when required for formulating their own guidelines for the hospital. So just to give you a brief background from about myself, I like majority of us, I started with adult retina practice, and then something happened and I switched to, and I got really interested, and now which is kind of really near to me, is the pediatric retina, especially the retinopathy of prematurity. So this was a young lady who approached to me. This was my third patient when I came to in private practice. Till then, I was not really interested in pediatric retina work. But then when I saw her getting bilaterally blind, unfortunately, because of retinopathy of prematurity, the things really stirred up within me. And then I thought that I should dedicate and consecrate at least one day of my practice for pediatric retina work. And that is how we conceived the proactive retinopathy of screening and management at NICU program in Gujarat. And now it has been one of the largest program for ROP. So till date, we have saved more than 10,000 plus babies. And we have conducted more than 150 plus neonatologists, because they are the key people when it comes to advising screening and treatment. One CME has been conducted in every major city of importance. And we have also distributed thousands of free brochures, which have been in vernacular language. A video has been put up in online on YouTube, so that all the pediatricians, ophthalmologists, and even the parents can see that video. We've done some pioneering work in the pediatric fundus photography and also in the ranibizumab. And I also run a Medicolegal group. So any one of you are interested, please do join the group, because we discuss cases which are pertinent for our medical legal profession, which is a medical legal thing, which is part of our profession, and also more so as a pediatric retina specialist. So this two India phenomena was a hot debate before a couple of months. And when I refer to ROP, I feel that nowhere else in India is this two India phenomena juxtaposed and more strikingly visible. And I have my reasons why I say this, because India harbors one of the highest number of ROP kids, and those who are potentially liable to get blind from ROP. So we have about 15 million premature babies per year, and at risk are not less than 6 lakhs. And with that, we have only 150 to 200 medical retina specialists, and who are really interested in we might have more surgeons, but then those who are really interested and trained in ROP care are really few. and a population of 1.4 billion. We just touched the highest population in the world yesterday. And visual loss from ROP is twice as high per million in India than majority of the Western countries. At the same time, given this skewed statistics, we have something which is kind of as evident as the other part of the story is that we have had cases from all across the nation, and no corner of the nation has been free. So we have been, every practitioner has burned their end, be it pediatrician, be it ophthalmologist, be it retina specialist, and there have been cases which have been class action lawsuits as far as these cases are concerned, and even anterior segment surgeon. So this Navsari case which I referred to is an anterior segment surgeon who was slammed with rupees 70 lakh cases. This was just recently in Gujarat before, say, a couple of months back. So this brings us to kind of, a situation wherein we need to think around that whether the formula, the current guidelines which we are formulating and the practice that we are doing, is it safe? And how does it go? Because when we talk about 100 to 150 pediatric retina specialists who are really delivering ROP care to the needful, we are kind of more scantier than the tiger. So and we need to we are 10 times lesser. So the thing is that the same time, if we are slammed with such a high lawsuits, then probably it's really tricky for any people to even touch the baby in the first place. So this particular case which I am referring to, which was probably one of the most recent one, in which the patient presented with the case of watering. So even a patient can present you of ROP with simple case of watering, the chief complaints being watering in a government OPD setup. And we all have worked in government OPD setup, and we know that how tricky it gets when it comes to advising ROP checkup in a government setup for an anterior segment surgeon. Please note that it's not a retina specialist to whom the patient is approached. Thereafter, unluckily, the patient got blind, and the suit was awarded. So please note that even if an anterior segment surgeon is kind of dealing with neonates, he needs to be careful and mindful of where he should be advising. This was one of the landmark cases which really stirred up the discussion in ROP in especially the pediatric side of the practice. That is and which was awarded 1.8 crore compensation, which is one of the highest in India. And it was based on restitutio in integrum. The actual expenses, the concept I shall be discussing in the next slide, but the broader part of it is that the actual expenses incurred by the patient, by the parents for the treatment were, passed on to the doctor. The prolonged period of mental agony, and the cases, because it lingered on for nearly 2 decades, there was a 36-fold increase in the compensation by the Supreme Court. So we need to understand this loss when it comes to ROP practice, because it is directly, there is a direct correlation between the thing that we are doing and the law. So it is based on the fact that the patient would have been put in the same position, और जो है वो उसको जो है वो वही position में नहीं रहता तो उसको क्या दिक्कत होती. The disability affecting his future normal life, the mental agony and the life experience and dependence and care, and 6% annual interest rate. Please understand, this is 6%. So we are not even getting 6% in our bank FD. We are supposed to pay 6% or even higher as per the RBI inflation data. So please understand that this 6% is not a mere 6%. As majority of you might be interested in personal finance and will be knowing the rule of 72. So the amount keeps on, if the case lingers on for several years together, the amount keeps on doubling every 10 years. So this you need to understand when we are dealing with the ROP cases. So like I said, that there are several cases, but we'll just be picking the broader crux of the entire case and not going into the details. So in the Ludhiana case, the screening was not documented. So you should be documenting the screening. That's what he learned from. And follow-up was not advised. So please understand that ROP babies are never normal, even to begin with. So you should be advising follow-up, and at least minimum 2 ROP checkups are required, especially when the baby is born preterm or extremely preterm. Even more might be required. And even if the baby is near term, and probably because of some indication, the pediatrician advise ROP checkup because the retina is not developed until 42 weeks of age, then probably you need to advise for, if the retina is mature, you need to advise ROP sequelae follow. So this is very must. Writing just no ROP type of report is a very big no-no, as Dr. Anil Gangwe also pointed out, that, there has been a case in Mumbai, which, the doctor was slammed with 5 lakh lawsuit because he wrote fundus within normal limits. So the ROP fundi are never normal, and we need to take care of what we should be putting on words. So similarly for the Delhi case, we know that once the pediatrician refers to you and the patient steps into your OPD, it's now the onus is on you. So it's just like a passing the parcel game. So you please be careful that now the pediatrician's liability is over the moment you take on to the case, and that is where your medical legal liability starts. So it should be an end detailed one. That is, the court has been really clear on this, and what Dr. Anil Gangwe sir has also stressed on his how meticulous we should be doing. Not advising ROP, the Chennai case that we discussed, and getting ROP checkup done, but not obtaining report from the ophthalmologist is same. Both should be done. So when we consider all these cases, and let us presume that God forbid, if some one of us would be slammed with a lawsuit for whatever reason, then probably the risk reward ratio. So I'm a stock market guy, so I always think in terms of risk reward. So if say I'm God forbid slammed with a lawsuit of 1 crore rupees, the charges which I keep for ROP checkup in my hometown is 1,000 rupees. So majority of us are doing it and treating it as a part of consultation. Please understand that I would strongly resist everyone to use the word screening, because screening, it itself is a very, it puts it in lower in the ladder. I would call it ROP checkup procedure. So ROP checkup procedure. So that is what is written in all my letterheads, on all my formats, and in all my even the patient education brochures, because that brings some seriousness to the thing. Otherwise, people just treat it as consultation. Even doctors sometimes treat it as consultation, and you can see how skewed the risk reward ratios are. So somebody who might be doing FNO and would be knowing that even the FNO has better statistics when it comes to the ROP thing. So 1 lakh is to 1. So in other words, say I will have to examine 1 lakh patients just in order to kind of just get rid of one lawsuit. Which if I were to examine say 1 lakh patients in my lifetime, I would be considering really lucky if I were able to manage to reach 10,000 plus. But say if I were able to reach 1 lakh patients, I could lose it all, everything, the proceeds from that procedure in just one patient. So this is how skewed the risk reward ratios are. So while we practice and advocate preventive medicine, that is what the part of the ROP is, the ROP checkup is. But let us also practice preventive medical jurisprudence. So this word needs to sink in, especially whenever we write ROP checkup or deal with ROP patients. So the issue with ROP is also not only technical, that it requires the highest level of IDO skills. The ultra short patient encounters, like patient has been with pediatrician for several months together, but when it comes to you, he's hardly there for 10 to 15 minutes. So he has no rapport. So building the rapport first, and then kind of, as a primary operation. So, somebody who's getting referred to you for diabetic retinopathy is a total different ball game altogether. He's been examined by general ophthalmologist and being referred to you. But when you are going to the patient doesn't feel the need for the screening itself, and then you are kind of trying to explain him the entire pathology of ROP within few minutes. It's really tricky. So sickest and the weakest patients are being brought to us, so that brings along with it several issues. No chief complaints, so that makes, like I said, things really tricky. Fundus photography itself is difficult, not unlike adults. The frequent change in guardianship, because sometimes the patient might be with the mother side of the family, and then next time somebody from the father side of the family props up in your OPD. So it gets really tricky. It's not the same patient. The patient himself doesn't understand what is happening around. The lack of awareness about the disease and the lower socioeconomic group, the highest medical legal compensations, the prolonged liability period. Please understand that whenever you're examining a pediatric patient, the patient can sue you till 18 plus 3 years of age. So recently, in one of the cases, the baby was born not because of the ROP, but because of spina bifida. And then this was in UK, and then she sued her gynecologist at around 21 years of age. So patient can do that until 21 years of age. So please be mindful that you might right now be in your late 30s or maybe even in early 40s. But then, at the age of 65, you don't want a lawsuit just, stemming out from nowhere, just because some clerical mistake which you did 75 years back. So please be so much meticulous in the ROP checkup and the documentation. So the broader part of our topic is going to be under these 4 heads. We need to understand that the ROP diagnosis is also not only tricky, but reporting and documentation, the legality of the treatment of ROP and the risk of the pediatric anesthesia also needs to be weighed in, apart from the technical complexity, the illiteracy, the class action lawsuit threat, and the lack of judicial areas in the clarity. So ROP report is worth its weight in gold, as Dr. Anil Gangwe sir already pointed out. And let us also briefly ask each time we check up, do ROP checkup of a young one, that, would you rather spend time in court for 12 weeks, 5 days a week from 9 a.m. to 5 p.m., or would you like, just spend 5 more minutes and write a proper report, the one which should be, written the way it should be done. So there have been studies which are probably not because of, for the ROP, but the other cases that, and those studies have proved that, 31% of the patients of the proved medical negligence had no consent, or had been really tricky, that the post-operative stage was, during the pre or the post-operative stage, the deficiency has been documented. So the excellence in medical documentation has been, it cannot be underlined further, and we need to, the courts also take it as a, around the world, it takes it as a positive. If you documented things properly, then probably it might have a, you might have a leeway in the, when the court cases do happen. So it needs to be not only documented, but it needs to be clear, a clear plan also, and the clear expectation which are aligned with the patient expectation also. So how do you do that? So a mnemonic for that is SOAP protocol, which has been advocated, in which you have a subjective, objective, opinion, options, and this is also for adult, maybe diabetic retinopathy, and be it whatever. A SOAP protocol is always a nice one to have in all your clinical endeavors, and so that you are really whatever you are thinking is being documented. Otherwise, what we are thinking is not documented, and that is where the trick lies for our lawyers when it comes to when the case does go to the court. So let us understand that the ROP tends to affect the sickest and the weakest of the infants, and only associate professor level or above should be dealing with the neonates. Because sometimes we have also done that when we were in residency, when pediatric usme jaake jo hai wo check karte hain. I know people are really burdened, but then this is something which is really serious, and if something is rested with residents who are probably not so skilled enough, then probably it gets really tricky. So who should examine is very clear. This was one of my patient. You can see, can you observe? This has been totally sinus. The patient was at home, has been discharged. One can see IT fit which was there, but this totally sinus baby. This happened right in my OPD, right in front of my eyes. Luckily, I have the protocol that I don't examine without a neonatologist around me, especially when I'm examining a patient who's been just discharged or has a Rayleigh tube in his mouth. So this was after revival. So you can see how much cyanosis it was, and how it was just within 5 minutes, that because it was in the NICU, and I always check the patients in NICU to the extent possible. So it was easy to revive the baby, and the pediatrician immediately took over. But then such tricky cases also happen. I have encountered 2 such instances in my lifetime. Another baby was really, was in my OPD, and thereafter the first instance, and but we could just tap the sole of the foot, and we could revive it with from the episode of apnea. But then sometimes it might not always be possible, and you need to put the patient on oxygen, which might not be readily available in our OPD, and we should be making amends for that as well. So the criteria for ROP has been really beautifully described by Dr. Subhadra Jalali ma'am, and I don't need to, it's a landmark paper for anybody who's practicing in India. And if pediatrician is saying you to come and check over the patient, please don't refuse. So the bottom line is that you might have your own indications, but don't form your own indication. Pediatrician is requesting, please go and check. Even how to manage the ROP, I'm not going into the details. It has been really described in the papers, and I'm not going into the details because that is not our point. Let us understand that the 30 to 40% of the patients, that is 1 in 3 child, undergoes all this ROP sequelae, and the patient should be clearly explained that you need to follow up even if there was no ROP on the first checkup, because then you don't want the patient to get blind just because and we have had such instances. It's not a theoretical thing. We do see such patients clinically. That is why we need to keep them under checkup. So role of REDCAM has been kind of advocated, but I would say that because it is, because the sensitivity differs from patient to patient, and also the patient factors as well as the biological factors as well as the technical factors, the three fundus field is versus 5 fundus field. You might lose, some few patients which might otherwise would be having, diagnosis of ROP, but which might be missed on a REDCAM. In such instances, even if we miss 1 patient in 100, tend to we don't want those, because even one patient, like I said, that can invite class action lawsuit, and then it gets really tricky. So I mean, the best part would be to use it with documentation. So there have been papers which have been published for regarding the analysis of discrepancy between the diagnostic clinical examination, and there were several instances in which the image reading did not detect the ROP on clinical examination. So 90% agreed. Even between the observers, there was a variation. So you don't want to kind of bank on things, especially as a private practitioner. See, please understand, majority of the guidelines, if you see, go and look. I use and I regularly view all these guidelines. They have been for somebody who's practicing in. They have been formulated by somebody who's practicing in institutes. Now, institute level practice and private practice, which majority of the young ophthalmologists are into, and are trying to battle the ROP disease with their small swords. It's way too different. So you need to understand that what works well for you and what doesn't work well for you. So I mean, if you keep on ad hoc adopting the guidelines, then probably it gets really tricky. Now, this was one thing which really came into my this thing, that the side of the US side doesn't feel that it is expensive, but 80 lakh red cam is really expensive for us, because over there they just compare it with the incubator for the baby, which itself costs $70,000 to $80,000. So I mean, that is how they see it. One interesting thing, of course, the expenses are expenses, and a private practitioner doesn't have the luxury with when he's paying from his own pocket. So this also needs to be understood. Even a 25 lakh instrument, let me tell you, even 25 lakh instruments, if you're going to charge 1,000 rupees, yes, if you're going to charge 10,000 rupees for a ROP checkup, it's a different story and a ball game altogether. But if you're going to charge, or even 5,000 rupees, you're going to charge 1,000 rupees, it really doesn't make sense, this thing. So we came up with this, hack or of a smart fundus photography, and this is one of the first patient which was treated for ROP. This is a pre-treatment and second day post-op treatment, reflecting how wonderful it works. These are the patients which were slightly old, 1.5-year-old, so it was really difficult to catch them, and we didn't find that general anesthesia should be used in them. But this is how one can manage to document some of the findings for ROP. Another one of the youngest retina snap, just for the amusement, I have kept it, but this was just clicked after 1 hour of the baby Harlequin syndrome being born. So probably one of the youngest retina snap in the world. Yeah. So coming back to our SOAP protocol, please understand that whatever documentation that we do, it should be, please add that name identified by parents. Now, this is very important thing, because there are twins or triplets. Now you really don't know, especially when the sex is different. I would strongly recommend, especially everybody who's dealing with ROP care, professionally, I mean, day in and day out, strip the baby down, open his diaper, and see that whether it's a male child or the female child, because parents have no clue, absolutely no clue, that whether this one is the T1 or this one is the T2 or whether it's a T3. They keep on goofing up. You need to write it down on your paper that as identified by the parents. Otherwise, things get really tricky in cases of twins. And rest of the details probably majority of us know, so I'm not going into detail. The communication, the documentation, and the documentation of the communication. These are the 3 central aspects which kind of are the heart of any clinical encounter, be it ROP or non-ROP. The fully documented record can forestall a lawsuit. Poorly documented can kind of invite one. There are benefits which we know from our kind of this thing. But then please understand that the jury is more likely to believe you if you have prepared a good chart and you have documented everything down. And then it also shows that you are a caring physician if the least. The medical liability of a specialist also know that is far more than that of a generalist. So if say somebody who's say anterior segment surgeon, who's general ophthalmologist, and he is examining ROP baby, and you are examining as a retina specialist, then probably your liability is 10 times more than that of a general ophthalmologist, because he has onus on him that moment he diagnoses or has some doubt, he refers it to a specialist. But a specialist can opt for a second opinion, but then whenever he documents the thing and whenever he mentions himself as a specialist, he has more liability than a generalist. So these are not the related to ROP in which these judgments have been given. These have been other aspects of the other branches of medicine. So probably say gynecologist or dermatologist or in other judgments, which Dr. Prakash Marathe sir and Dr. Deshpande sir can probably relate to. But I mean, this is how it works when it comes to the ROP. So the same things applies to us as well. please clearly mention that is advised follow up on so and so date, but the patient has refused or has dropped out on same and has approached us only today. Even if before even you check up, in case of a dropout, please write this, because this happens 2 or 3 times and it is there on paper. The court also realizes that the patient is a chronic dropout, and then it would more likely to benefit you. The management part, I'm not really going into detail. Majority of us know the management, but the urgent word is really important whenever you are advising treatment, and you need to underline it as well, and probably use a marker of some sort so that it gets highlighted. Whenever you are kind of otherwise also whenever you are not advising treatment, you need to understand that you need to write these 4 lines. Case discussed with the neonatologist, chances of progression to retinal detachment, whatever. In case of AP-ROP, more than 80%. In cases of borderline ROP, that is pre-threshold high risk or low risk disease, depending upon how much you feel it. This is purely subjective. Need for strict close follow-up advice and follow-up time, date, and place. So this all needs to be documented. Otherwise, you can be caught anywhere. And this is what the courts wants from us as well. So it's not something which of my own, but this has been what has been communicated in the court judgment as well. So please write this word and underline it, parents to decide. So, automatically, or the patient to decide as a part of default, this thing, please write patient to decide or parents to decide in the last. So that will save kind of, that will put the ball in the patient's court, that whether whatever decision they have chosen, whether they have chosen the opinion of second opinion, or whether they have chose for urgent treatment or whatever it is, is now their this thing, and it shows that you have kind of put the ball in their court, and you have taken their consent as well that you have been given. So this I have already discussed. The stamp signature of information, like Dr. Anil Gangwe sir put it, spatial consent form for ROP status intimation form. So the moment it becomes a high risk disease or an AP-ROP diagnosis, then probably it becomes you need to intimate the patient, and you need to take a countersign as well. This should be done as a default also, as an examination consent, whether it's an adult, whether it is a pediatric. But ROP consent form is really must whenever the patient has, you feel that has, now we have taken it by default because patient dropouts are really high when it comes to ROP. So we have made it as a by default procedure, and we take it every time the patient comes to us. So yes, that increases our burden, but then probably this thing, and we keep the one of the photocopy of the report with us. No original goes to the patient himself. The single biggest problem in the communication is the illusion that it has taken place. So we are in our own thoughts. We tell that the patient understands from our intellect, but the patient intellect is usually way too low. I mean, we would not understand if say somebody who's a mechanic, who's a car mechanic, uses his jargon and tries to explain us, or say software engineer and tries to explain us on our laptop, which has kind of gotten dismantled. We probably would not understand what he's saying about. So same thing goes for the patient. If you understand things from the patient points of view, they are not wrong altogether. But then, that is where the biggest gap is, and that is where the lawsuits stem from. So even when there is an agreed plan, which should always be there at the end of the treatment, please write the advised treatment, but the patient chooses to go for a second opinion. Because a 24 or 48-hour delay in ROP case, it might, your diabetic retinopathy patients can go on for several months together. But for this particular ROP case, a 24-hour delay could be really, a difference between the blindness and the otherwise. So please always document these things, and all such precautions are supposed to be taken, which Dr. Anil Gangwe sir has already taken. But I would really stress on the second part of which I told, that let us understand the ROP is also socio-economic disease, because majority of the times the patients are poorer in their background. And ethics is knowing the difference, but that also puts a question of ethics when it comes to advising the treatment for ROP, and which molecule you are using as going to use as a practitioner. So ethics is knowing the difference between what is right to do and what is the right thing. So societal guidelines, please understand, or medical expert opinions are purely based on the discretion of the court. So you might feel that, okay, society guideline has said this, and I'm protected, and I'm using XYZ molecule, that is why I'm safe. Please understand that the court has to decide. You feel that, okay, say Dr. XYZ is my kind of nice friend, But if the court doesn't allow, and the court has all the right to disallow expert medical opinion, and it has disallowed in certain few cases, then probably, that point of the matter is cancelled there and there itself. So this you need to understand. And we have such, we have papers also. So this is not from my opinion. Enforceability of the government. So even the government directions, policies and guidelines in the contracts are kind of, this thing. Forget about our societal guidelines, and any society, anybody can form society with 20 to 25 people joining together can form a society. So say 5 of us can join together and form a society. So it's not at all a big deal. But those guidelines don't stand in court. Even the government directions and policies guidelines don't stand in court of law whenever there is when the matter comes to the court. In otherwise cases, it's really fine. So this was this one case in which the guidelines or the executive instructions which are not laws. So it should be a law of the land, and it should not be a guideline. So guideline is kind of, आप कर सकते हो, नहीं भी होगा, ऐसा करना जरूरी है, and a kind of this thing. Law is a law. So I mean, please know the difference between the law and the guideline. I don't need to underline these things further. So this was one recent this thing that only one approved molecule right now in case of ROP is Eylea. Is the first pharmacological treatment in infants, but ranibizumab has received this is the US FDA approval, and this and what we are talking about is the Indian approval and the other thing, because we are practicing in India. So let us consider that a foreign couple comes to India for IVF and undergoes treatment here, and I get many such these things and undergoes therapy here. And say you use a molecule which was not kind of a legal molecule in the first place. Forget about a molecule which is altogether off-label. So there is a huge difference between off-label and illegal. So which was not legal in the first place, and why I would be saying illegal, I'll be coming in the next few slides. But then probably then you are वो तो वही बोलेगा कि भाई जो है आपने US FDA approved जो है वो नहीं use किया है. So it gets really tricky in such cases. In spurious files, so we have had instances of spurious files, many reported. I don't need to cite anybody over here. But then many cases of spurious files and what happens during those periods. And also understand that Indian Avastin is different from the American Avastin or UK Avastin, because over there, the compounding pharmacy is preparing the Avastin and not the doctor. Here we kind of, prepare pouches and whatever as mentioned in the guidelines. So it's way too different. There is a joint responsibility between the compounding pharmacist and the doctor. And if there is an episode, we need to kind of this thing. So this was a very case, probably the doctor is no more, so and no harm kind of quoting that. But this was in 2018. This has been after the guidelines for use of Avastin has been kind of published by the various ophthalmic forums, and this was the verdict given thereafter. So please understand that those guidelines don't stand in front of law, and probably off-label is the word used for the same tissue but different indication for which the approval is granted. So if I'm using, say 10 years back, if I was using say ranibizumab, I mean Eccentrix, or then Lucentis for diabetic retinopathy, it was off-label. Avastin could not be termed as off-label because it was not meant for use in the eye in the first place. And when such court case happened, and these are the court rulings, I'm citing the court rulings, and it's not my own that I'm putting forward to. It has not been approved in any eye indications, and this is what the company, the Roche, when was Roche का जो है वो जो chief था, उसको जो है वो court में बुलाया गया था, and it was asked that it advocates treatment only by intravenous route, and complainant has proved to prove any manufacturing defect in the produce. So this was very clear cut, this thing when it came to Avastin. So this, without the use of the approval of the US FDA, EMA, or Indian health authorities, constituting negligence on the opposite party, and the wordings. So please understand that this needs to be really this thing. The company clearly told that paper card पे तो जो है वो लिखा है कि भाई to be sold only by the registered oncologist. So how come you use Avastin when it is meant to be? आपके पास आया ही कहाँ से वायर? So that's where the question comes into the play. So whether you should be using Indian biosimilar or you should not be using. Let's understand the quality control which comes from. This was one instance in which, and there have been many other instances as well. But see, the difference between the adult and the pediatric is in adult you are using it as one-off. आप एक बार use कर रहे हो, फिर जो है वो दूसरी eye पे जो है you are going to treat probably after a week, or maybe after a month. But here you are using it as an emergency desperate measure in both the eyes and almost simultaneously. So this is where the difference stems from. So if you cannot afford to lose either eye. Let us also consider the patient is with the cerebral terminal matrix hemorrhage during its development and develops squint. And the patient alleges that it was because of your Avastin or your molecule this has happened, or the squint or whatever this thing has happened because of you. Then how do you go and disprove that? Okay, now it was not my injection which has led to that. So these are the technical difficulties which probably one is likely to face, and we don't need to wait for. See, sometimes what the societies tell that we have not had a single case of which was related to ophthalmologist or in which ophthalmologist was implicated for use of this. So I don't need to wait for first I break the law, then I go to the case, and then till that I keep on breaking the case. So ऐसा नहीं होता breaking the laws. ऐसा नहीं होता. You need to understand what has been the rulings and use the different context, whether it's adult or pediatric, and use it in relation to the pediatric. Patient assures follow-up, signs it, but does not follow. What do you do in such case? And how do you deal with it? So one of the recommendations has been phone calls and certified letters to both the patients and the pediatricians. But then, it gets really tricky in the Indian context when the patients don't pick up the phone calls itself. So we have all encountered such instances. And then, the joint responsibility is almost never there on the part of the patient. And sometimes the patient might die because of some unrelated thing itself. And then probably somebody might allege that it was because of your treatment. So this was one case in which the patient had been awarded 1 crore compensation for the death of the child during squint surgery. Might not be because of the ROP, but then, the patient died because during the squint surgery or because during the treatment, the patient died. And in another instance in which the patient died and there was a ruckus which was created by the relatives. So please understand these few medico-legal facts very clearly. There is zero or no mercy when the patient has lost one or both the eyes from when it comes to the court of law. Even a simple case of vitreous hemorrhage from Avastin, which was probably a chance happening because the patient had PVD, which is probably bound to happen with anybody and everybody's case post intravitreal treatment, and the consumer court has awarded compensation. So the only solution to this problem, especially the treatment part, what I feel is what we take the government into this thing. Merely kind of applying to DGCI and getting their approval is not going to this thing. We need to do what UK physicians have done. The lawfulness of the policy was changed by Bayer and company, and that the legal decision has to come from the court and has to come from it needs to be the law of the land, or a special law has to be formulated. That is where we can probably use Avastin in kids, and the special NHS bodies can lawfully offer a patient's choice of being treated with the Avastin or at a fraction of cost for the Eylea patient. So we need to go the UK way and get laws framed which are protective for us. The last few recommendations, we need to be confident. If you were to practice ROP as a ongoing thing, we need to have immunity. Like I told, that we are rare than the tigers in India, and probably we need better legal protection from the government. Proper prescribed format, as Dr. Anil Gangwe sir has already stressed upon, cannot be. We need to use that, and this need to be approved by battery of lawyers. Please understand कि एक दो मैं बोल दूं कि ये मेरा consent form आप ले लो और आप बोल दो कि आप वाला मैं ले लूं. It will not be there. We need to think from the lawyer's perspective. We do not leave any loophole, even such a high implications and high lawsuits which are awarded. Strict adherence to the protocols, that it should come at a spinal level. Very aggressive ROP literacy campaigning needs to be done so that everybody, the patient should understand. I mean, the pediatricians and the doctors ophthalmologists have understood, but the pediatricians should understand the importance of this ROP thing. And we have failed to, imbibe the concept of life-saving medicines. To have we have steroids have life-saving medicines and put it under, say, DPCA. But we have failed to understand, implicate the importance of the sight-saving medicines. So this Avastin is a sight-saving medicine, and this needs to be inculcated in the minds of government, those who are sitting in the government. Also, as a last thing, especially what we can do as an ordinary practitioner sitting in remote corner of the country and trying to battle ROP with a small sword, document, because the pale list ink is better than the strongest memory. And these are all the references from which we have taken the thing. And thank you all for a very patient listening. Hope I have tried to scratch the problem which the young ophthalmologists, especially the standalone ophthalmologists face, because many things in many conferences, the big things are discussed, but then let us understand that what holds true from somebody who's practicing in an institute and the private practice are way too different. And somebody who's really reached to a seniority level, say of 50-60 years age, he has his white hair to kind of back his whatever mishap has happened. So the white hair itself prevents many mishaps. The young ophthalmologist probably doesn't have those protective coverings, and then probably he or she might invite a lawsuit or two. And if today's lecture could probably prevent a few lawsuits, I would really consider it as a worthwhile. Thank you all, and thank you, YOSI, for inviting me.
Thank you very much, sir. That was a really wonderful talk and a really extensive talk for covering each and every aspect of ROP. Now, I would like to invite Dr. Anand Deshpande sir and Prakash Marathi sir to give their valuable inputs.
Hello, I think it was a wonderful talk by both A's, Dr. Akash and Dr. Gangwe. So wonderful talks and very well covered. Few important tips we wanted to give, but so much time is already utilized by those talks. So we'll be very brief. One important thing is that this ROP checkup done by ophthalmologists should be precise with vitreoretinal specialists. I think general ophthalmologist cannot do that. What's your take on this? Suppose general ophthalmologist is being referred this type of patient by neonatologist or pediatrician, and general ophthalmologist just cannot check it and cannot give the opinion and cannot tell about exact proper follow-up. So at that time, what his role should be? Whether he should send that patient back to neonatologist and tell him that you should send this to VR, or he should refer that patient to VR and not to be in between. Just quick comment.
Just that, if see retinopathy of, so there is a usually this is conflict of interest, whether I should be examining or you should be examining, or X should be examining, Y should be examining. Retinopathy of prematurity. So the word itself contains retinopathy. So it should be examined by retina specialist. So there itself the thing has been solved. Number one thing. Number two thing, there are two instances wherein this thing comes into the play. Whether see somebody is, say, right now what is happening, especially in towns of Gujarat, so even a smaller town of say 1 to 2 lakh population, such kids are being really saved. So say somebody who's really good in IDO and checking the patients, he or she might screen it like we do, say like a retina specialist screens for glaucoma, but then immediately refers to the glaucoma specialist. So he probably can check it, so there is no harm checking, but then he needs to immediately refer it to a retina specialist, whether it's a medical retina specialist or a vitreoretina specialist who's there around. But it is his duty to refer to him. If he doesn't refer, then probably, and if the mishap happens, as long as nothing happens, everything is fine. But should a mishap happen, then it gets really tricky in such a case. So that is where.
Thank you. My question to Dr. Anil sir, I think you are talking about some ROP drops. Just for information to general ophthalmologists and others, what exactly that means? ROP drops.
Sir, basically ROP drops for general ophthalmologists will be a combination of tropicacil and phenylephrine. And for adult, we are using phenylephrine in the concentration of 5%. For preterm and neonates, we reduce the concentration of phenylephrine to 2.5%. So initially, we need to dilute the adult tropicacil plus with artificial tear so as to reduce the concentration. Nowadays, these drops, which are designated specially for neonates, they are commercially available in the half concentration. So these are the dilating drops actually for preparing the baby for examination.
Thank you. I'll be speaking afterwards. Let Dr. Anand Deshpande say something.
Yeah, the thing is that the ROP should be referred to a vitreoretinal surgeon preferably. But if there is no vitreoretinal surgeon nearby or in the town, then he can be referred to a ophthalmologist who is trained in seeing the retina or who supposes himself that he is efficient to see the retina. Because there is no differentiation of the law that who should see the retina and who should not see the retina. Because law is not dictating it. That is the practice. The judges decides that the expert should be available, but if the expert's not available, then compromise can be there, but should not be neglected that it is not told to the patient, so that the patient can go to a higher center and have a consultation there. If the consultation is not there available when he is in the NICU.
I think there is one vehicle, small two-wheeler, on which that pentagram, I mean, all cameras and everything can be set by the technician, maybe optometrist, or maybe somebody who is helping the doctors and can take images. So medically, how okay is it, or that practice which is used in periphery in India, the country like India, where medical retina specialist or where is not available everywhere? What's your take, Dr. Anil, sir?
Yeah, it comes under the
Anand, sir.
telemedicine. It comes under the telemedicine laws. And as such, there is no law made for the telemedicine. There are only the guidelines which are established, and those are followed. And it is as good as seeing the patient exactly in person. The real thing is that if the vehicle is of some hospital, or then the responsibility of that hospital comes the person who are there going in the villages or somewhere and screening the ROP. Their responsibility lies upon the surgeons and hospital who is supplying that. And if it is a government thing, then the government himself is responsible. So there is no question in that. So government has to appoint the particular experts only.
Sir, in this case, I think ophthalmologist, pediatric ophthalmologist, medical retina specialist, VR specialist, and then from pediatrician side, pediatrician, neonatologist. And is there some role of gynecologist also?
Yeah, gynecologist has the first role that they should inform the pediatrician or the pediatrician if and admit the patient to the NICU. Then the link starts. Because either the pediatrician attend the delivery, and whenever such baby is there, they should admit in their NICU, or the gynecologist should have their own NICU, which is looked after by the pediatrician. So gynecologist, pediatrician, ophthalmologist, vitreoretinal surgeon, all these are required things in the link. And most of the important is documentation. If there is something somewhere lacking of the documentation, everything is then gone. Because many times it happens, there is no documentation.
I think whenever the patient is there, like premature birth, or there is a suspicion from neonatologist or pediatrician, and then the child is referred to ophthalmologist or medical retina specialist or VR. But one of the speakers said that whenever the child comes or infant comes with the complaint of watering, it is really difficult to differentiate that routine watering because of, say, lacrimal, all that apparatus defect, or some probing type thing can be managing all that, or it is to be dissociated from ROP. It is really difficult for general ophthalmologist point of view, that particular differentiation. So what is that exact demarcation line of that watering patient? Watering infant, rather.
You treat as a, even as a, sometimes we get as a retina specialist also, we get such complaints of watering. So middle way out could be that you treat it, but you document it on paper that advise ROP checkup. So we have those checklists in which all the ROP checkup should be this thing. It's really difficult for a general ophthalmologist to recall that in the time of OPD, in middle of the busy OPD. If 32 weeks, less than say 1800 gram or less than 2000 gram, तो वो सब कुछ याद रखना बहुत ही difficult होता है. So what you do is you treat the baby for whatever the Mositoba or whatever drops you are prescribing, but then you document it on paper that you advise ROP checkup with a retina specialist. So that is the only middle way out for somebody who's.
I think in Dr. Anil's talk, he said, and that's what I want to stress again, that American standard of writing the date and Indian standard of writing the date, that is day, month, year, and month, day, year, that is really confusing. Suppose it is 7/3 means whether it is 7th March or 3rd July. It is really very difficult and patient can challenge, because suppose you ask the patient, why didn't you bring the child? The parents, they say that, okay, this is the date written. So what he has already told you about, specifically write the month. And that is the specific thing what patients and the relatives, not patient in this case, but the relatives must be informed properly. And there has been one medical legal case in this regard, because the patient said that I was not called on this particular date, and patient came 6 months afterwards, and there was some medical legal litigation. So that is very important point, not from ROP point of view, but even most of the times when we enter the date on our case papers, that should be completely perfectly written so that it prevents future litigations.
One precaution.
Questions on Google Forms.
Yes, yes, Kaushik.
Can you take them, sir?
One precaution which I would like to suggest here is, please write both the things. So 0, 15 days. So what I do is I like 0, 1 and 5, or 0, 7 whenever I advise checkup, and then to follow it through, I write the day and the day, so that there are 3 methodologies by which the patient can tally, or the court can tally, or the lawyer can tally that okay, the date was really correct in the sense. So I always write in such format that zeros come after 0, 7 days, and on such a day, and I mean Wednesday, Thursday, Friday, or whatever it is, and then the date. So that precaution is a mandatory precaution. Yes, sir.
Good. Kaushik, you wanted to say something?
Yes, sir. There was a question: can I practice ROP if my clinic doesn't have PICU or NICU? I think Dr. Anil sir has already answered.
You don't need.
Yeah, Kaushik, most of the time you might have babies who are walking in to your clinic, and you can actually examine them. However, in our scenario, again, as Dr. Akash was saying, we are backed up with our pediatric anesthetist who is just up on the first floor. So we are backed up. So we can actually do ROP screening. However, you must be prepared, or at least you must have some basic idea about some neonatal resuscitation, and you must have some contact with your NICU or PICU people in such kind of scenario. However, it is not mandatory to have NICU or PICU to practice at least ROP screening. But for treatment, treatment is must in NICU. You should not take up the chance of doing laser in your clinic.
Never.
How many days should the... Yes, sir.
Yeah.
Yes, sir. There was a question by Dr. Arti. How many days should the record be maintained for ROP patients?
I think Prakash has answered it.
Or anything. The
Like the
rules
child
are
at
there.
the age of 21,
At least 2
then
years.
after that, so better to maintain it lifelong. Why to
And
dispose?
yeah, it is very easy nowadays with the computers. You can feed the computers and forget it. Whenever required, you can bring it out.
Very important. Sorry, Kaushik, if you have a question, please go ahead.
Yes, sir. There was one question. It was a long question that somebody treated a patient with anti-VGA.
I think Kaushik, I had gone through the Dr. Gaurav Kohli's question.
Already there.
Questions.
Yes, sir.
So I would like to answer that he had asymmetric kind of a response in a baby whom he had injected with injection ranibizumab. So asymmetric response is a well-known thing, and again, if it was a asymmetric kind of a response, he could document it. It is better to document if at all, as Dr. Akash has said, whatever photographic documentation methodology you have, you should try and document it first thing. If not possible, I think he has documented it using the diagrams. So no problem. He can do it with the diagrams also, a legible kind of diagrams with labeling, and always try to mention asymmetry of the disease may not be depicted in the diagram, but again, he could be very clear that I have found a asymmetric kind of a response. I would like to follow up the baby closely for the asymmetry, or if there is progression in that particular eye. And if at all there is any hesitancy, again, never hesitate to take a second opinion from your colleague. Just discuss these things with the parents very openly and frankly that, okay, these are the things I'm seeing. I have not seen this before. If at all there is any literature which is supporting this, you can, again, if the parents are literate enough to understand what are you trying to say, then you must discuss this with, and even with this condition, you should not take up, you can take a second opinion. So discussing the things clearly with the parents would help actually. And in his scenario, again, as most of our mentors also say, it is one of our ophthalmologists or colleagues who is actually putting you into the trouble. So as a colleague or as a professional, we must be very careful about pointing out some of the discrepancies in the record or in the findings whenever we are disclosing it to the patients or parents.
Sir,
Question
there
in
was
the chat
another,
box. Sir.
another
Is there
question
any-
on. Yes, sir. Prakash, sir, please.
There's a question in the chat box from Dr. Sarthak Bafna that sometimes there are multiple dot blot hemorrhages.
Yeah, Dipanshu, I think I answered him directly. I have messaged him.
Okay, thank you. Thank you.
We can still discuss it, Dipanshu, for others. No?
Okay.
So if you can,
So, yeah.
I think I got one important occasion to say. When I was MOS president, I used to move around all districts of Maharashtra. And those days in 2017, I went to Buldhana, where number of ophthalmologists were limited. And the CME was on this topic, that is ROP. So I was wondering how many ophthalmologists will be attending. When I went into the hall and the topics were discussed, the hall was full. I said, how come, how many ophthalmologists are there in the city and this hall is full? They said that we combined this CME with ophthalmologists and pediatricians, and that was the need of the hour. So most of the times when we have such programs of ROP, I think Dr. Akash has done wonderful work. Dr. Anil also has been doing wonderful work. These physical meetings, most of the times you invite neonatologists, pediatricians also, so that the proper message is also given to these people. And these should be the combined efforts from ophthalmologists and pediatricians. That's what I feel.
Right, sir. Very true.
Anil, sir, what was the answer of this, the multiple hemorrhages patient?
If there are multiple hemorrhages in the fundus, we first thing we should discuss it with the pediatrician that if there is any underlying hematological disorder. Most commonly, what we will see is most of these babies, they would be anemic and they might have thrombocytopenia associated with this. And even with the slightest amount of scleral depression, you can get intraretinal hemorrhages, or they might be there pre-existing. So actually, most of them will resolve without any treatment. We just need to inform the pediatrician that they need to get a hemogram done. And if hemogram is normal, then they should again work out for some septic focus, because sepsis is also a common cause of getting intraretinal hemorrhages. And in relatively larger babies, again, rule out a shaken baby syndrome in such kind of a condition.
There is one more suggestion is there that whenever there is a NICU or in the hospital of a gynecologist, there should be posters which show that the retina should be examined by the ophthalmologist within 30 days and with the photo of the baby, which is published by the government also, that poster, that should be posted everywhere in the NICU and gynecologist department, so that the people become aware of that and ask what is this, and then many times the problem is solved.
And actually, this is a nice suggestion, and sir, we have been doing it. Whichever NICUs we are visiting, we have pasted a large photographs showing the preterm babies and the retina, which is right in front of the NICU, so that the parents can actually see them, and it has helped us. Yeah.
So this type of, it is visible.
Yes.
This type of poster is published by the government, that this type of the poster should be displayed in the NICU and gynec hospitals, so that the people become aware.
Perfect.
I have shared one YouTube link to a video which is prepared for patient education, pediatric education. Please feel free to see it and circulate it.
Yes, sir. So there was a question in the Google form, like medical legal aspects of ROP surgery for stage 4A and beyond.
So I think, okay, that was again a question by Dr. Gaurav Kohli. Okay, so yeah, anyone who has a vitreoretinal surgical exposure and at least has got some pediatric vitreoretinal exposure can actually go for ROP surgery. However, the person has to be very well versed with the anatomical differences between a typical adult retina and eyeball compared to a pediatric. That is a technical part of it. If you go from the medical legal aspect, it is not majorly primarily the surgery which will be a problem. It will be the anesthesia and anesthesia related problems which can be a major source of trouble. So again, get a very good preoperative pre-anesthetic checkup. Again, usually in adults we don't go for echo and everything, but if you are going to take up clearance, get a pediatric clearance. If needed, go for an additional echocardiography. You must have a good or at least an experienced pediatric anesthetist or anesthetist who have been doing or operating congenital cataract kind of cases for years together. So someone who is experienced enough. And again, NICU backup, at least the NICUs where you are visiting or PSUs where you are visiting, you should inform these people that we are going to take so and so case. And if at all, in the rarest of the rare situation, if something is not right, we would like to ship the baby to your NICU. A formal documentation of all those stuff has to be there in the record. And most importantly, the parents of the such a baby must be explained that we are just looking at the eye and retina, we are going to operate. However, all those anesthesia related complications can actually occur and you must be prepared. The parental counseling is extremely important in the medical legal part of the story.
Thank you.
There was another question. If patients deny treatment at the time of diagnosis and later the child gets blind due to ROP, can the doctor be held responsible legally?
For that purposes, we should
need
get
to-
in written from the patient that they are refusing the treatment or the examination, and that should be signed and thumb impression should be given of the parents and with the witnesses. And preferably, if it is under the surveillance of camera, it is the best thing. Then nobody can go in the court against the doctor.
And even in such cases, sir, even such kind of scenario do happen to us also. So in such we are taking it writing in the whatever language the patient is able to write. We do take their signature, and as a witness, we also take a pediatrician's signature at the same time that even we have informed the pediatrician has spoken to the parents, still they don't want to undergo further treatment.
The pediatrician also documents it. The pediatrician also has to document. And one few precautions which I suggest to the pediatrician, please write that, you have advised ROP checkup on so-and-so date with so-and-so Dr. Anil Gangwe, Dr. Akash Patel, whosoever it is, with so-and-so contact number or whatever the format should be. It should be on your case. So you might be writing a refer note, but then, they need to write it. I mean, they need to document this. Even in the cases of follow-up. So what happens is sometimes you go to the NICU and then you check and then you follow up. So pediatrician should be documenting it even in the records also that, okay, ROP checkup scheduled with Dr. So-and-so on so-and-so date. So these are the small things which, matter a lot when the thing comes to the court. So.
Well, sir, there was another last question. Is it mandatory to take consent for examining premature infant? I think Anil sir has already shown.
Adult or pediatric, you need to take an examination consent. Please understand that, see, we don't realize this and we take it naively. The thing is that, as a retina specialist, especially, you are seeing the patient in a closed chamber with the lights off. So, especially if it's the patient from opposite sex. So it's a male, surgeon and the female patient and vice versa. You need to take all the precautions which are needed for examination of the patients. What happens is the corporate hospitals do it by default. The government hospitals are protected by the law and some things are deemed and nobody, really this thing. So, but for when it comes to standalone private practitioners, You need to take a consent and also understand that this is a procedure. Like I demonstrated in one of my patients, the patient could have died in my OPD itself. So how do you deal with such a situation? It has got no relation with me. The patient sustained an apnea, which was probably prolonged apnea, got cynosed, and kind of really went down. So how do you deal with such a situation? So you need to take the consent of the parents. The moment you examine the baby, the moment the baby enters your clinic, or say you go to their clinic and examine, you go to the NICU and examine, you need to take a consent, valid consent. So yes, an informed written consent, because what happens is the baby doesn't get blind because of the ROP, but say gets blinded, the patient never turns up. Say initial ROP checkup was totally normal. Retina was vascularized until zone 3, mature retina in the first checkup itself. But say probably got blind because of the amblyopia, or got blind because of some XYZ cause, which has got no relation. Like I said, that germinal matrix hemorrhage. Now you have nothing to do with the germinal matrix hemorrhage in the brain, and the patient got squint. The patient's relative said, okay, you said that the eyes were normal, and we have such instances in private practice, wherein such instances have happened. जो है वो आपने तो जो है वो आपने इंजेक्शन दिया था, या आपने जो है वो बोला था कि भाई आंख तो सही है, अब इसकी आंख टेढ़ी क्यों हो गई? So we don't want such issues. So you need to mention everything in the consent form also. Such issues can crop up. That is why, like I said, that we need to develop those consent forms which are approved by battery of lawyers and ophthalmologists together, and not only one or two, like me copying say Dr. Anil and Dr. Anil copying mine. So it doesn't work that way. We need to think from all medico-legal point of view. That is probably way of better dealing with such issues.
No, are there any more questions? I don't think so, sir. We have answered, I think, a lot of questions. A good discussion has happened. Kaushik sir, can you close the meeting if there are no more questions?
Yes, sir. Thanks, Dr. Anand sir and Dr. Prakash sir, for always guiding us. It was excellent to hear Anil sir and Akash sir. There was extensive discussion on this topic, and it is actually very relevant and very important. And in times to come, this will be one of the major aspects in which medical legal cases will be done, and very huge compensation will be claimed. So I think our audiences will, and we also learned something new today, and it will help us in managing our cases and preventing the ROP-related blindness later. Thank you all. Thanks to all the audiences, and thanks Dr. Aarti and Dr. Dipanshu. With permission from Anand sir and Prakash sir, we'll like to conclude the session.
Thank you.
Thank you.
Thank you, sir.
Okay.